Some of you may have been here for the last lecture, and what we decided last time was that I'd got a lot to say and a lot of information, and it was too much for one lecture. So tonight is the second half of that, as Deirdre says. To make it a bit more accessible, I'm just going to very quickly run through, and I'm literally just going to skimp over the slides just to show you what you missed last time if you weren't here. Though the lecture from last time, again, those slides are available from Migraine Association Ireland, and I believe that the lecture is on a YouTube also available from there, from the first half of this. So I'm just going to show you what we went through, but I'm not going to go into any detail. It's just going to be a very, very quick 3 to 5 minutes of just showing you what we discussed, so you know the context of what you can go and look at if you want to have a look at that. So just try and actually work out how, there we are. So that was part one last time, and so don't worry if this is suddenly going through really quickly and you can't keep up, especially if you've only just joined. This is just a very brief, not a recap, but just showing you what we talked about. So last time we talked about a lot of the sort of other symptoms in headache, why it's important, why we don't want to miss nasty things, why when a lot of places, a lot of things, even the World Health Organization talk about the disability of migraine, they talk about what we recognize and what's diagnosed as migraine. But for so many people, it's not even recognized, it's not even diagnosed. So a lot of it flies below the radar, because if you haven't been diagnosed, no one's even going to record you in their statistics when looking at the diagnosis. And misdiagnosis rates can be up to 60 to 80% when we look at studies. I talked a bit about how people used to be thought to have psychiatric problems, but now we recognize them as migraine, and it becomes very obvious once you actually recognize and see patients. So the main focus of last time's talk was the migraine comorbidities. We went through sort of general comorbidities. Sorry, I'm just trying to move forward. We talked quite a bit about migraine and stroke, and that was quite a large part of the talk. Just also a little bit about patent foramen ovale, whether it's worth closing it, mechanisms, and I gave a sort of summary of what I consider to be the bottom line between migraine and patent foramen ovale. We talked quite a bit about the sort of bidirectional relationships between migraine and psychiatric disorders. I've just realized if you press it more than once, it keeps going forward. And then I talked about migraine in terms of being a systematic and multiple symptomatic disorder, who might get it, the sort of rather than the complicated pathophysiology diagrams that you may come across in lectures where people show wiring circuits in the brain. I talked about 3 main areas which I think are important in migraine: the way the brain amplifies your perception of obviously things like noise and light, but it can be many other things, including sensation becoming pain. I talked how your brain can be functioning abnormally, so things like sleep, mood disturbance, memory. And I talked quite a bit about autonomic disturbance, which is where you have the automatic nerves being overactive, and that can be in the body, things like blood pressure, pulse, dizziness, sweating. It can be in the head with things like a droopy eye, a watery eye, a stuffy nose, a runny nose, a sensation of fullness in the ear. You can understand how people with these sort of problems can get sent to the wrong place if they're not complaining primarily of pain, but more of a stuffy nose or fullness in the ear. You can see how the ear, nose, and throat consultant gets hold of you and then decides to operate on you, and the anaesthetist makes you better for 2 or 3 months with a general anaesthetic, and the ENT surgeon takes the credit for it, and then 3 months later you're back with your migraine, and it's all come back again because no one ever actually, it wasn't ever an ear or a nose problem. I talked about complicated wiring circuits in the brain, and I sort of looked at it in terms of these different phenomena. We linked it to the 4 different stages of the migraine attack and how various politicians may show us all the premonitory features, from craving food to yawning to intense despair to, well, I don't quite know how to describe the bottom right character, sort of anger, aggression. I'm only going on the picture here. I'm not obviously making any political comments. We talked about aura, patient's perception, and we talked about just a list of recognized non-headache symptoms of migraine that could relate either to the mental state, neurological type symptoms, or general body symptoms. We talked how migraine could be anywhere. And we talked about the non-headache symptoms. And this is a slide that I sort of set up about 20 years ago. And increasingly, other people are recognizing these sort of overall associations. It's taken many years to convince people that this is migraine and not necessarily madness. And there's a very long history going back over at least 100 to 150 years of people with migraine being diagnosed as having a psychiatric disorder, not migraine, because people didn't really recognize how these things fit together. We briefly commented on the real importance of not asking about how many headache days you have, but how many days are you crystal clear and headache free, and the concept that when you're crystal clear and headache free, generally the other symptoms of migraine will often disappear. So the person who is absolutely normal in mood on one of those crystal clear days shouldn't really, in my view, be treated for depression. They should be treated for migraine, and then see if the depression goes, because there's a high likelihood that it will. The same goes with other things like restless leg syndrome. If you're getting no symptoms of restless legs at all for the 10 or so days a month, you're completely crystal clear, head is absolutely 100% normal, then the restless legs are secondary to the migraine. Whereas if you still have restless legs on those days, that may be actually causing very low mood, very poor sleep, which may be actually exacerbating and perpetuating your migraine. And that's quite an important concept. And I mentioned about some useful information at that stage. I don't think I've put that necessarily at the end of the slide, but again, if you do get slides later, if anyone does wish to get a private consultation, I do them all remotely by video these days. There is that potential, there are the contacts there, and this is a booklet that we wrote for the NHS, or I wrote for the NHS Vanguard, and I think quite excitingly, if I'm allowed to share this news, we're probably going to be looking at a new booklet for Migraine Association Ireland, which is going to take this as a sort of recognised booklet within the NHS in England, and change it not necessarily to something that suits your healthcare system, which I don't know the term you'd use for it. Is it bonkers, possibly, Deirdre? Your healthcare system is running into a few difficulties. We're not much better here in England either. But I'm not trying, the booklet we're going to define isn't going to be for trying to cope with your health system, but really trying to help yourself and know where to seek advice and for what. And we're going to try and expand on what we've already written to make it a bit more a bit wider really in its remit of understanding everything. So with that in mind, oh, hold on, that wasn't supposed to happen. We're on to part 2, and we're on to tonight's lecture. So this is part 2, non-headache features of migraine. So the first thing I wanted to talk about was Alice in Wonderland syndrome. And a lot of people aren't really aware of this. And I remember giving a talk at one of the Northwest UK psychiatrists, and there were about 100 people or so in the room. And this was about, I don't know, 12 years ago. And when I'd given a talk, at least 3 people came up to me afterwards and said, do you know what? I've never dared tell anyone about my experiences that I had when I was a child, because I thought people would think I was mad. And these were psychiatrists who still thought that they'd had some sort of madness in childhood. And actually, when I did actually ask the room, it was way more than 3 people who'd experienced this. It's not as uncommon as we think. So if we think about Alice in Wonderland, so this is part of the original text, and it shows this picture just shows a very, very elongated and distorted Alice looking extremely tall with a very, very long neck. So what we're talking about with Alice in Wonderland syndrome is distortion of reality. And in this context, we're talking about it as a manifestation of migraine. Migraine is not the only time that you can get Alice in Wonderland syndrome, but I think it's by far the most common. It can happen in the context of epilepsy, but I must admit I've seen a lot of patients with epilepsy, and I've never seen Alice in Wonderland syndrome in that context. It can also happen following certain infections. So particularly infections in childhood like glandular fever, Epstein-Barr virus. You see this, but migraine is by far the most common cause of this. So when we're talking about distortion of reality, and I'm going to come on to Alice in Wonderland syndrome in its own so on its own and go through that in a bit more detail in a minute. I just want to talk about distortion of reality generally as a manifestation of migraine, and I suspect somewhere around 20% of you out there will have had aura at some stage, and that could be visual aura. Usually patients have visual aura as the main aura. We talked about this last time. Often it would start as an area of blurred vision, or you wouldn't be able to see through it. You know it's not just one eye, because often it affects the center of your vision. People's faces, bits of people's faces, or the television may be missing, which tells me it's not in one eye, even if it's over to one side. If you all just try this at home, just put one hand in front of one eye, and you can still see the whole computer screen or whatever, or your phone in front of you. In other words, one eye sees both sides. So often it starts to one side of your vision, but fairly close to the center of your vision. And that means it's actually a phenomenon occurring in the back of the brain, usually where you've got a spread of electrical change in activity, gradually spreading over maybe over 15, 20 or 40 minutes over the cortex, the surface of the brain. And as it comes to each new part of the surface of the brain that's responsible for something different, it will give you different symptoms. So the visual loss may gradually get bigger. It may evolve most commonly in a sort of C shape or a curved shape, often with scintillations or zigzags around the edge. Some people it all goes blurred. Some people get just absolutely sure it's just one eye. So we do see variations on this. Teleopsia we see in migraine, and that's zoom vision. So things that appear to be zooming in and out. Surroundings may appear very big or very small, and these sort of things we're talking about are really these are the Alice in Wonderland features, which I'll come on to in a bit. So teleopsia, surroundings may appear very big or very small. I've had patients who feel like they're getting too big for the room, they're going to get squashed. I had a patient who, interestingly, he said that he remembers walking down the road, and as he was walking down the road, he saw this toddler running towards him. He was absolutely petrified that the toddler was going to stand on him. So you can see how bizarre these things can sound. And I've even had some people who have families who have had these sort of same things. My mum used to find that when she was a little child, the wardrobe would suddenly appear absolutely huge in the corner of the bedroom or something like that. Body image disturbances, often seen. So these are where body parts appear very large. They can appear very small. They can appear distorted in size. Some people even complain of reduplicated or absent limbs. So I had a patient who was driving, who they basically felt that their left arm was absent and they couldn't change gear because they didn't have a left arm. So you can imagine that being a bit frightening. Entomopia, or insect eye, or multiple images, multiple copies. For those of you old enough, imagine Bohemian Rhapsody, Queen, whichever year it was. I'm sure if this was a quiz, I could get loads of people shouting back at the screen saying which year that was on top of the pops. But that iconic image of all of them singing Scaramouche and all the rest of it. I won't sing because I could get my fiddle out. I've got my fiddle here, but I won't do that tonight. So insect eye images, corona phenomena, things having a halo. Now I'm very wary. I normally make a bit of a joke at this point in my lecture, but it's slightly biblically sensitive, and whilst that includes both Protestants and Catholics, and I'm Jewish, so it includes all of us, but people looking at halos around people, you just wonder whether some of those halos could have been corona phenomena. You're seeing someone and they're looking as if they've got a halo around them. You can get that as part of migraine as a phenomena when it's Alice in Wonderland syndrome. Hallucinations can be all sorts, and we always think of hallucinations generally as either things you see or things you hear, but it can be things you smell, olfactory, it can be things you taste, gustatory, it can be tactile. I had a patient who broke his arm as a result of Alice in Wonderland syndrome. He was cycling through the woods along a cycle track, and he basically swerved to avoid an oncoming steam train. Okay, so in the middle of woods, literally cycle track through the trees, he swerved to get out the way of a steam train that was coming towards him. This chap also worked as a hairdresser, and he basically got the feeling that he had got dog excrement on his hands, and he couldn't get it off. Everything he was trying to smell, everything he was trying to touch with his hands was smelling of. So he touched the taps, and then they stank. And he was in his hair salon trying to get these things off. And he ended up giving up hairdressing because the actual hair products that he used were always triggering his headaches. So it's quite tricky. Some people get distortion of reality in the way they think. So cognitive deficit, they can't actually work out how to use their limbs or how to name things, or they become confused. I've had a patient who is quite interesting. So foreign accent syndrome, you may have heard of. It's this concept where people start talking in a foreign accent. You see these things. If you look it up online, you'll see different people reporting this. So someone who suddenly starts talking in a Chinese accent or something like that. And I work in Liverpool, and this guy came into my clinic, and he'd had a bang on the head. He had a really nasty headache disorder, and he was severely affected. He was in bed 2/3 of the month, vomiting, really, really bad, new daily persistent headache. He'd had it for about 5 years. And he also had foreign accent syndrome as well. And he'd had this ever since he'd banged his head and had his head injury. And he came in, and I'd done some nerve block injections, and his headache had disappeared for 6 months. And so I turned round to him and said, "You must feel over the moon." And he turned round, he said, in a broad Geordie accent, "I feel like absolute shite. How would you feel walking down effing Scotland Road," which is a road in Liverpool, sounding like an effing Geordie? And everyone was taking the mickey out of him. Well, and you can't say that anymore, so yeah, what I mean. Delusions, paranoid psychosis. So that's a sort of distortion of reality that you can see as migraine. And you can see why people get seen by psychiatrists or other practitioners and get diagnosed as a non-physical disorder. So Alice in Wonderland syndrome, if we're looking back to that, when was it first properly recognized? It was probably about 1952, and Lippmann described these as certain hallucinations peculiar to migraine, and noted these to often appear as migraine equivalents, in which the hallucinations sort of constituted the entire attack. So the examples in Lippmann's paper included the left ear ballooning out by 6 inches or more, or the patient felt short and wide, calling it a Tweedledum or Tweedledee feeling. And actually, when we opened the new wing, there's a whole new building at the Walton Centre, I actually we were asked to put 12 photos in the new outpatient area, 12 pictures that represent neurology. And all my colleagues were putting slides of prion disease like CJD, or they were looking at MRI scans of brains in Parkinson's disease and things. I actually gave them a picture of Tweedledum and Tweedledee and said, "There you are, that's headache and Alice in Wonderland syndrome." Other things, body split in 2 halves, as if split by a vertical line, with the right size twice the size of the left. That was one of his patients. Another patient had an attack where she feels small, about 1 foot high. Another one, I feel my body is growing larger and larger until it seems to occupy the whole room. So these were the initial descriptions, which were thought to be certain hallucinations peculiar to migraine. Now, in 1955, the syndrome was named by Todd, who described these as a singular group of symptoms intimately associated with migraine and epilepsy, and gave it the name Alice in Wonderland syndrome. So this is a psychopathological syndrome of distorted space, visual perception, time, and body image. And the core symptoms of the paroxysmal body image disturbance are that the feeling that the entire body or parts of the body have been altered in shape and size. We love to give things long Greek or Latin names, so we call it metamorphosia. And the only reason I put these next 2 names in is because it took me ages to learn how to say them. So macrosomatagnosia and microsomatagnosia. So these are distortions where you feel part of your body is huge or part of it's very small. And you might be looking at your arm and it just looks as if it's completely the wrong size. Interestingly, if you take someone who has lost an arm and they develop phantom limb pain and phantom limb experience as if their arm is still there. And I often use the phantom limb and the loss of an arm. I use that analysis for people who don't recognize that your brain can turn on pain and turn off pain. And the example I often use to patients to say, look, pain is felt in the brain. Someone on a battlefield will actually feel that they might have their limb blown off, but they won't feel pain necessarily for 30 or 40 minutes afterwards. And that's because their heightened adrenaline, their mood, everything is absolutely wound up to full fight and flight, and that completely turns off pain. So you can imagine someone has just had their arm blown off, yet they can't feel it. Yet 4 months later, they're now feeling severe pain in a limb that's no longer there. And that's phantom limb pain. So even though there's no pain, they know that that's it. They've got an itch they can't scratch because there's no hand there. They've got a pain that they can't press on or do anything because there's just nothing there. They're feeling around for a limb that's just nothing there. But the point I was going to make is, and this is the way the brain can create illusions. Someone with phantom limb pain, not only do they feel pain in their limb, but their limb shrinks so that instead of feeling pain all the way down what was their limb feels like it just comes down to about there, and they'll have a tiny little hand, a much smaller hand about here, not a big hand down here. So it basically, the way your brain alters things, it can think things are much smaller or changed. Now in this situation, where you're looking at your limb and it looks huge and it feels huge, and it's your limb is reaching over to the door, or it's only reaching a few inches from your body. The other core symptoms of paroxysmal body image disturbance include out-of-body experiences or feeling a presence. And then you get facultative symptoms, depersonalization and derealization. I recognize these as symptoms in migraine when I first started getting interested in headaches, so 25 plus years ago, that a lot of people feel dissociated, and a lot of people say it's like walking like Mr. Soft, or I feel like I'm just walking on a cloud. I don't feel real, or my surroundings, I just don't feel connected. And the analogy I often give in clinic is it's a bit like driving a car, but you've got your foot almost fully down on the clutch. So you're just not actually engaging your gears. You're not actually connecting with things. You're just floating through life. Visual illusions occur. So macropsia, micropsia, teleopsia, which is things that look much bigger, things that look much smaller, or repeated images, or things that are zooming in and out. And then disorders of time perception, the clock going very slowly or very fast. And I'm sure at Glastonbury, when I was just there this weekend, a lot of people will have had very similar experiences, but not due to migraine. So the bizarre visual illusions and spatial distortions, I've mentioned these things looking far too big, far too small, sensation of formed body distortions, or zoom vision, things zooming in and out, things speeding up, slowing down. Alice in Wonderland syndrome is more commonly reported in children. Now, whether it's more common in children is difficult to know. Children aren't quite so worried about being cast off by men in white coats as adults. So a lot of children will say things, whereas adults will often be reluctant to disclose these. One thing I've noticed with these problems, and I've seen quite a lot of patients with this, is that they often occur in the premonitory or aura phase of headache. So they often occur before the main headache phase, and they're often followed by headache. Now that's not always, but that's often when we see them. Okay. And as I mentioned at the bottom, drug ingestion can do it. So things like psilocybin, magic mushrooms and things have been reported. So here's just a few examples from publications. So these are the corona phenomena. So you can see the halos around objects. And I didn't purposely put an icon from a sort of Russian Orthodox church with a halo on it because I thought that might be blasphemous. Here we go again, halo phenomena or corona phenomena. And interestingly, this is a patient who's got visual aura on the right. So they've got a field disturbance which isn't seeing. They can't see on the right. It's all gone blobby and funny. But where they can see, everything's got sort of slightly double ghosted images behind it. This is I mean, this is all migraine art, so I'm guessing what the people were talking about when they gave these images. These weren't put in the book, Podol and Robinson's publication, or the book on migraine art that I've got. They weren't put in the book saying, I've got Alice in Wonderland phenomena. I've just gone through a book on migraine art, and I've gone through these publications, and these are published pictures that patients have put out. So I'm presuming that these people have got Alice in Wonderland, splitting of the body image. Here you've got splitting of the body image, but also the clear zigzaggy distortions and blobs and flashes of light of visual aura. So again, interesting that it's distorting vision and giving visual aura at the same time as we're getting this split in half type feeling. I love this picture. I think it's brilliant. This is, again, it's migraine art from a migraineur. And they've not said they've got Alice in Wonderland, but this is what the head feels like in an attack. Macrosomatoagnosia. So again, small body, huge head. And there we are with Alice in the book, one of the illustrations with her looking much too big for the room. This was a teacher who was teaching, and not only has she got visual aura, as you can see around her eye, so she's got visual aura, she's got a dysphasia, which is a speech aura. So she's saying the stribthan was not most of it. She's talking rubbish. I know most of us used to think our teachers talk rubbish. Apologies for any teachers out there, but she is actually talking rubbish. This is dysphasia. And if you look at her arm here, in fact, both arms, you'll see that instead of a normal size, she's got this huge feeling of a huge long arm. So you can imagine how frightened some people get with this. And that's someone else's migraine art. And you can see what they look like walking along this lovely beach, but feeling absolutely huge. Someone with no head. Right. So Lewis Carroll's Alice books based upon migrainous experience. So Lewis Carroll, 1885. It's Charles Ludwig Dodgson is the name of Lewis Carroll. That was Lewis Carroll was the pen name. And interestingly, actually, Charles Ludwig Dodgson came from Daresbury, which is right next door to Spire Cheshire Hospital, where I've had my private clinics for many years. And I used to drive down past where he used to live. So in 1885, first diary entry alluding to migraine, and he put experience for the second time that odd optical affection of seeing moving fortifications followed by a headache. So that's 1885. I don't know if I've explained before, the term fortifications or fortification spectra are the zigzags that we see around the edge of something. And if anyone looks at the sort of aerial pictures of castles through Holland or France, you'll get the castles will be different walls, and they'll all have these sort of zigzaggy parts around them, and then you have another wall with zigzaggy parts. So it represents, it basically looks like a European castle from the air. The Alice books were written in 1864 to 1865, so before this first diary entry in 1885. And Podol and Robinson discovered a sketch. These are the people that published on the migraine art. They discovered a sketch from 1855 to 1862 showing an elf-like figure, meticulously drawn, except for the fact that he is missing the right side of his face, as well as portions of his right shoulder, wrist, and hand. This was to be noted to be negative scotoma, in other words, something missing, with a rounded border defect. And Lewis Carroll apparently consulted Mr. Bowman, an oculist or eye specialist, about my right eye. He does not seem to think anything can be done to remedy it, but recommends me not to read at a long time, or long at a time. So there you go, it's a bit of history for you. So where are we talking about in the brain? No one knows. We wonder whether it may be due to the or rather based in phenomena occurring in the cortex, which is the surface of the brain, the grey matter. That might explain why we see distortions of time and space, or things going very large or very small. Could it be a result of more widespread pathology, the back of the eye, the retina, or the optic chiasm, where the optic nerves join up behind the eyes, or could it even be in some of the main sort of deep in the lobes of the brain, to give much more of a sort of conceptual problem? And Brazis, who's written an amazing book on anatomy of the brain and localization of where problems come in neurology, which part of the brain they come from. He wondered about these particular areas. And then in 2004, Evans and Rolack thought this may be a parietal lobe phenomenon. And the parietal lobe is really interesting. This is the bit that's, if you think of your brain, that you've got the frontal lobes here, and then you've got the parietal lobes behind them. Underneath them, you've got your temporal lobes, and at the back, you've got your occipital lobes. Now, the occipital lobes are where vision goes. The temporal lobes are memory and hearing and speech to some extent. The parietal lobes can be speech, but they're often very much associated with how we interpret things in time and space. So you can imagine why people thought the parietal lobes were potentially implicated. And then people did do a sort of functional imaging scan, what we call a SPECT scan, a nuclear imaging scan in a girl with Alice in Wonderland, and they actually showed it to be some disturbance in the right frontoparietal region, where the brain wasn't quite as well perfused with blood. So that's interesting. And then we compare this to what's called peduncular hallucinosis, which is a different type of hallucination that we see. It's very different to this, where those problems usually arise in the brainstem, where the brain connects to the spinal cord. But those are very different phenomena. The patient in those situations will know that what they're seeing is not real, and it will be very, very dissociative and not real, sort of oneroid quality. But in peduncular hallucinosis, that's also noted to give things that are very, very small. So these things need to be found out. And to be honest, no one's really interested in this or writing about this. I did actually contribute some cases to a book chapter on this, so it's a small pet interest of mine. Right, so moving on from the sort of slightly bizarre to the more common and potentially more troublesome symptoms amongst most migraineurs. I think fatigue is a really big issue. It's common. So if we look at the fatigue severity scale, which is a scale that people use to measure how bad your fatigue is with conditions such as chronic fatigue syndrome, 84% of people scored greater than 3 on this fatigue severity scale. This is generally in chronic migraineurs. And 67% met American criteria for the chronic fatigue syndrome. In other words, just by having migraine, they met the criteria for chronic fatigue syndrome based upon the level of fatigue they had. It's really important, if any of you are diagnosed with chronic fatigue syndrome and migraine, to recognize that chronic fatigue syndrome cannot actually be diagnosed in the context of another recognized cause of your fatigue syndrome. And my experience of patients who've been through chronic fatigue services is that very rarely are they asked a sleep history. Very rarely are they asked about things like obstructive sleep apnea or restless leg syndrome. Very rarely people actually take a history of when they get to sleep, what their sleep quality is like. These days, whether they wear an Apple, Fitbit or Garmin to measure their sleep, they just don't look at it. They tend to just say, right, well, you've got fatigue, we'll give you that, we'll do this, we'll get you to see an occupational therapist, we'll do graded exercising for you. But if you've got fatigue and you've got migraine, we shouldn't be able to diagnose chronic fatigue syndrome. And I think that's really important. And if you're the sort of person with chronic migraine who gets some days, even if it's rarely, where you are crystal clear and headache free, you have to ask yourself the question, does my fatigue go? If your fatigue goes, then the fatigue is part of your migraine. If your fatigue doesn't go, then you should also ask yourself, am I obese? Do I have a large neck? Do I snore heavily at night? Do I stop breathing? Because obstructive sleep apnea causes headaches and fatigue. And patients with obstructive sleep apnea will usually be noted to snore heavily. They will stop breathing at night. They may wake up choking. They often pass urine a few times at night. They often wake up particularly headachy, and they may even wake up feeling quite shaky. And yet once they're up and about for a while, the headache and the shakiness tend to get better, but they still feel fatigued in the day and they will fall asleep. They get micro sleeps. People with sleep apnea, they did a fantastic study where they put little cameras on the sun flap of HGV drivers, and they just took footage of them driving, and then they asked them a sleep history and they asked them about snoring and heavy snoring and symptoms of obstructive sleep apnea, and whether they ever fell asleep in the day. And they found a significant number of people actually who were obese, and it's easier to be obese if you're driving a lorry all day for 20 hours without exercising and just needing to snack on food to keep awake and stuff. But they found that those people who had obstructive sleep apnea, who didn't fall asleep in the day, were actually having micro sleeps very, very commonly. And this is the problem. So people who have sleep apnea will often fall asleep for half a second and not be aware of it. Maybe 2/3 of a second, maybe even a second. But if you imagine you're doing 70 miles an hour down the outside or the middle lane of a motorway overtaking a truck, and you fall asleep for a second, that can have dire consequences. So it's always worth asking about sleep apnea if you're still getting fatigue on your headache-free days. And it's definitely worth asking about restless legs, because I think somewhere up to 80% of people with migraine have evidence of restless legs when you take a detailed history. So headaches commonly not volunteered by patients when they present with other complaints. We often see people who come in who say, well, my main complaint is tingling, or my main complaint is sleepiness or fatigue, or my main problem is I just can't think straight, my memory's poor, I think I'm getting demented. And if you ask them if they've got a headache, even then, they may go, not really. But if you ask the other way around, how many days of the month does your head from the morning to night feel 100% crystal clear and headache-free? Absolutely normal, no pressure, tightness, aching, throbbing, stabbing. Oh, well, there's always something that doesn't bother me. It just feels fuzzy. It just feels like a bit of pressure. But that's not why I'm here. I'm here because of the tingling, the fact that I can't think straight, my fatigue. So it's really important when we take the history that we do it right. So I think that chronic migraine should be considered in all patients presenting with chronic fatigue, and I think that sleep disorders, particularly restless legs and sleep apnea, should be considered. Migraine-related dizziness, and I really do apologise if any of you get dizzy looking at stripes or escalators. You don't have to keep looking at the screen. I'll tell you when I forwarded it. But migraine-related, in fact, I'll forward it now because even I'm getting a bit dizzy. So migraine-related dizziness. This is my personal view. I think there are a number of different things that can happen with migraine to give you dizziness. The most common thing I think of is migraine-related disequilibrium. But I think of four main types of dizziness with migraine. I think of migraine-related disequilibrium, which I'll come back to, migraine vertigo, visual vertigo, and unexplained veering to one side. If we look at what happens in a migraineur, I think the commonest by far is this migraine-related disequilibrium or migraine-associated dissociation. Now, I wanted to use the term migraine-associated dissociation, and I nearly coined this in fact, I think I put it in my early lectures, because no one, this is my experience. This isn't in textbooks. This has gradually been recognized over the years. And when I first started my job, I was thought of as nuts talking about this. You know, my consultant colleagues said patients with dizziness should never be sent to a neurologist. And I think they're wrong. But I also realized the acronym I was going to use, migraine-associated disequilibrium or migraine-associated dizziness, would be wrong because that signs out as mad. So, and that's exactly what I didn't want people to be thinking of patients with these things. But the disequilibrium or dissociation is often feeling lightheaded, dissociated, depersonalized, or even feeling unreal in yourself, or your surroundings feel unreal. Some people, when this is very bad, may even get secondary panic with this, and they may get slightly blurred, dim or spotty vision, or hot, sweaty and flushed. And these symptoms may be worse in hot, bright, noisy and crowded places. And you can see how people with these sort of symptoms get diagnosed as having panic disorder or panic attacks. And if you go to a neurologist saying, I go dizzy, lightheaded, my hands and feet and face tingle, and my vision goes a bit blurry, and I get a lump in my throat, and I can't swallow, they'll say you've got panic attacks or panic disorder. But I actually got interested in panic disorder because I was seeing all these things in migraine, and these patients were being diagnosed as having panic attacks or panic disorder. And initially, when I started out in neurology, I was even giving some of these patients SSRI treatments for panic disorder, but actually I don't think that's the right thing now because the antidepressant drugs often worsen your sleep. Migraine vertigo is the true feeling that you or the room are moving when you're in a migraine, in any phase of the migraine. So it could be in the premonitory or the aura phase, or in the headache phase, or even afterwards in the postdromal phase. The most common one with that is actually a feeling of being on a boat, you're swaying. It's much rarer to see patients with migraine vertigo who are truly room spinning dizziness. If it's room spinning dizziness, I really want to rule out an inner ear problem. And that's really important because there's a real bidirectional relationship between dizziness and headache disorders. So we see headache disorder like migraine causing these 4 types of dizziness I'm talking about now. But I also see people who never really suffered with headaches until they got an episode of an inner ear disturbance. They had a new onset of labyrinthitis with rotatory dizziness that lasted 4 weeks, couldn't get out of bed and vomiting for 4 weeks. Or they've had it with their Meniere's disease where they've got high-pitched buzzing, they've lost their top line of hearing, their top sort of frequencies of hearing, and they've had spells where they lose a bit more hearing, they get rotatory vertigo, and more tinnitus, and then maybe 2 years later they have another episode, and that's Meniere's disease in older people. Or they've had what we call BPPV, or benign paroxysmal positional vertigo, which many of you may have had. It's where you lie down or you move your head and suddenly for 15 seconds the room spins and you feel awful, but then if you stay still it stops again, and that's due to little bits of debris in the inner ear. Anyone who's had a bad head injury often will knock off the little bits of hair cells, and you get a bit of damage in the inner ear with a bad fracture or something, and that can give you post-traumatic otolithiasis, which is the same thing. It's BPPV. It's this phenomenon where you've got these bits of debris in your semicircular canals. You've got in the ear, you've got like 3 round sort of canals all at right angles to each other. I've only got 2 hands, so I can't put the third one in there. You've got these canals at right angles that are a bit like donuts, and they've got fluid in them, and they've got little hair cells inside that will recognize if fluids going backwards and forwards related to the movement of the canal. So patients with those sort of inner ear problems can then trigger a post-traumatic headache. You know, the inner ear pathology, in my view, can lead to what's like a post-traumatic migraine or a different type of headache disorder. So occasionally people start with a very clearly defined ear, nose, and throat disorder affecting the inner ear, and they go on to migraine. But by far the most common thing is that in up to 80% of people, they will note that when they've got migraine and it's become chronic, they often feel a bit detached and lightheaded. Occasionally, when they've got a bad headache, they get migraine vertigo where they feel that the room is moving or they're moving. This slight swaying is the most common. Visual vertigo is what we just looked at a second ago, where blinds, often vertical blinds, stripy shirts, escalators, even computers, Channel 4 documentaries in the UK where they go in and out with the camera shots too much. You know, those things make you quite dizzy. And then I think people also get unexplained. They just veer off to one side and they come in worried by this, but we examine them, it's normal. Interestingly, when we see the bad migraine vertigo, when it's been really severe, people often feel a bit better actually if they're in a moving object. So people often report feeling better in a car than when they're not in a car. It's not always the way, and I've got 1 or 2 people who it's the other way around. The important thing with these things is to treat the headache disorder and see what you're left with, and also just to be absolutely certain when, as a doctor, you're seeing someone, they haven't got a much more typical inner ear disturbance. We want to know their examination's normal. We want to know that there's nothing that makes us think that it's related to one of the inner ears. I used to think that patients with severe migraine vertigo were absolutely typical of migraine, and we treat the migraine and it's likely to go. But over the years, I've become a bit more concerned that there are quite a few people when this is really, really severe and the headache is daily and persistent. So in other words, with a new daily persistent headache where the headache never disappears 100%, and they've got very severe migraine vertigo, I think that is actually incredibly difficult to treat. But then new daily persistent headache is incredibly difficult to treat. So, as I mentioned, migraine commonly causes dizziness, but vestibular disorders may be a traumatic trigger to induce new daily persistent headache of migraine phenotype with or without vertigo. We treat this the same way as we treat migraine. We eliminate painkillers, caffeine and triptans, especially if it's a daily phenomenon. Occasionally, we use a drug called beta-histine. Try and avoid using frequent or regular drugs like Bucostem, which is otherwise known as prochlorperazine, because you just substitute one problem with another. If people stay on these drugs too long, they end up looking a bit like someone with Parkinson's or on a psychiatric medication, where they might get sort of movements of the mouth, or you might start getting dystonic movements where you're a bit writhy, or you might even just go very Parkinsonian with loss of facial expressions and very quiet voice, and you walk with a shuffle and you don't swing your arms. So those sort of things you want to watch out for, because frequent Bucostem on a daily basis can give you that. You consider using a migraine preventative drug. You consider getting a physiotherapist to look at balanced reconditioning exercises along what we're doing. We make sure there's no other vestibular disorder, particularly BPPV, that merits its own treatment. BPPV, this problem with the semicircular canals, if you can get the patient, I don't know if you remember those little puzzles you have when you're a child, where you get the ball and you try and get it in through the hole in a slot, in a little game thing. Well, treating BPPV is the same. You've got your semicircular canals, and they're all connected to something called the saccule next door to them. And if you can move the patient in the right way, you can get the debris to fall through the hole into the saccule, and then they're fine for years. And that's called an Epley maneuver, EPLEY. And you can look up how to do it yourself online. If you look up modified Epley maneuver, if you've got BPPV, you can actually treat it yourself quite effectively. We try the best migraine preventives we can, but I consider using drugs like flunarizine or venlafaxine earlier. There's no evidence here. There's no research trials. There's no double-blinded blah, blah, blah trial to say, oh, this drug works better than another. But in our experience, drugs like flunarizine work quite well for non-headache symptoms, quite effective where many other drugs don't work. And venlafaxine potentially has a slightly better effect in migraine vertigo. One thing, you'll go to your GP and you say, I've got migraine, I've got vertigo, and my consultant said that I ought to have a beta blocker or candesartan to treat this. And your GP will say you can't have those because you've already got low blood pressure. And that's actually, although it sounds correct, because blood pressure drugs lower blood pressure, if we look at what's happening to lower patients' blood pressure, if we look at people who faint due to low blood pressure, one of the commonest reasons for that is migraine, what we call migraine syncope, or fainting because of migraine. And patients will faint. They will often stay unconscious for more than a few minutes, even if they're flat. It's not always postural. And actually, because of that, and because a lot of these patients get diagnosed as having vasovagal syncope when they're standing up, beta blockers have actually become the first line choice in treating vasovagal syncope. This concept that you've stood up and then you've gone dizzy and you've blacked out. But beta blockers, drugs at lower blood pressure, are the first line choice in vasovagal syncope, a condition caused by low blood pressure. And that sounds crazy, but if you remember, migraine is a brain disorder. If we can turn off the autonomic circuits or modify those autonomic nerve circuits in the brain, we can stop the nerves being so twitchy with changes in posture, and we can stop people potentially blacking out. So don't be put off by beta blockers or candesartan, blood pressure drugs. They may often stabilize your blood pressure. We used to always say, oh yeah, people with migraine often have high blood pressure. In my experience, people with migraine more commonly complain of low blood pressure than high blood pressure. And a low blood pressure does not stop you having a beta blocker or a candesartan. You just go up slowly, gently. And if you get to a level which is making you dizzy when you stand up, you come back down one level, stay there for a while, a few weeks. Yeah, dizziness is gone. Right, good. I'm going to give it 3 months to see if this starts to work. Obviously, if you go to a level which is just going to be reducing your blood pressure because of its effect on blood pressure per se, you're never going to be much better. So people with low blood pressure who get headaches will actually find that we see this in elderly patients who are over-treated. They've gone to GP, they've been stressed, they couldn't find a parking space, the GP measures their blood pressure, it's too high, they get started on a blood pressure treatment even though their blood pressure at home was normal, and it drops their blood pressure even more than it was at home, and then they go dizzy and faint. And we see this all the time. But if you got very, very gently on these drugs, then you won't actually get that problem. So we got to a level that doesn't make you dizzy and give it time. I know that's quite a complicated concept, but if there are questions on that, I can always try and answer them if people aren't sure what I've been saying there. Now, restless leg syndrome, I think, is really important. And this is where we're going to talk a bit about sleep disorders as the main last part of the lecture. So Thomas Willis, who was an amazing physician, 1672, described restless leg syndrome. And he described it as, wherefore to some, when abed they betake themselves to sleep, presently in the arms and legs, leapings and contractions of the tendons, and so greater restlessness and tossing of their members ensue. I usually get a chuckle when I do that one live. I've never understood why people laugh at that line. That if the diseased are no more able to sleep than if they were in the place of the greatest torture. So anyone with restless legs will know that it's a condition where you may get jumps and twitches. It's not just legs. It can be arms, it can be back, it can be anywhere in the body. There's even a restless genital syndrome. So people talk about that. So people, they get this feeling that they want to move, feeling of discomfort is unpleasant. They may get tingling, they may get numbness. And when they get up and walk around, it goes away. And these symptoms are much worse towards the evening. When you wake up in the morning, people often feel quite stiff and achy, particularly in the lower half of their body. But within 10, 15 minutes of getting up and walking around, they feel fine. So this is described in 1672. And then if we're going to look at other people who actually diagnosed it, it was initially thought to be a sign of hysteria. So people thought to be hysterical or neurotic. 1800s. In 1944, a neurologist called Ekbom published this as a observational review of 34 cases, and he described diurnal pattern of lower extremity paresthesia coupled with a compulsion to move, worsening with rest and alleviated by movement. And that's a fantastic description of it, except I would say that whilst it's mainly in the lower limbs, for some people it can be worse in the arms, and it can affect the whole trunk as well. So restless legs, I've put this slide up as a picture of Dracula because that's supposed to represent anemia. Has anyone ever been to their GP and they've said, oh, I'm really tired, and your GP does your blood test and say, you've got low iron, but you're not anemic. In other words, your hemoglobin's normal, but you've got low iron. I'll give you some iron because you're tired. And they get better, and no one questions why it should make you better when you're not anemic. So I'm just going to have a sip of my decaffeinated coffee. Sorry about that. But no one's questioned why should you be tired if you're not anemic? You've just got low iron stores. The reason probably is that low iron stores cause restless legs. Restless legs destroys your sleep quality and destroys your sleep architecture. And this is probably one of the most prevalent conditions to affect sleep. And for sleep, we all need to have the right amount of sleep between, I don't know, 10 or 11 p.m. and 7 a.m. or whatever. We need it to be uninterrupted. Anyone who's got young children knows even when you had a good night and they only cried once, you still woke up exhausted. So you don't want it interrupted. And we want to make sure that you've got the right sleep cycle. So you want to know that you're going through the light and deep phases of sleep properly through the night in the proper order. And if you don't go through the light and deep phase of sleep, you won't be refreshed. And that deep sleep is really important because that's where your brain repairs itself. It's where you consolidate your memories for the day. That's what we believe. So if you want good cognition, you want good memory, you need good sleep. If you don't have good sleep, you get low mood, you get irritability. Just imagine any junior doctors know how awful you are. You get panic attacks, you feel anxiety, you get fatigued, you feel depressed. You get all these things because your sleep has been destroyed. So restless legs is a condition with considerable clinical morbidity. It causes a lot of symptoms, a lot of problems. There's no objective evidence of a neurological abnormality. We examine people and they look normal when we tap them with the reflex hammers and things. Just occasionally people have a neuropathy where they have sort of a glove and stocking loss of sensation that's constantly there. People, for instance, with diabetes, they might have up to their knees and maybe up to their wrists, they can't feel things. They may have restless legs as part of their condition, but for everyone else, they have a normal examination, but they have this feeling of restless legs, which is a brain disorder. It's very common. It often runs in families, and it's noted to be associated with pregnancy, where you lose iron. iron deficiency anemia, where you lose iron, blood donors, where you lose iron, and cancer, where you lose iron. Do you see the sort of theme there? So it's characterized by unpleasant creeping or crawling sensations deep within the lower legs, most commonly distal to knees, but as I said, it can be anywhere. It can occur in the arms. It's usually, but not always, less severe there. It's most commonly bilateral, but occasionally we see it just unilaterally. It should only be experienced after rest, but it's very common for people to say it's been much worse when I've been doing a lot of exercise or moving around, and then when I go and rest, it's bad. So it's often made worse by exercise. In other words, it doesn't happen during exercise, but if you've been exercising a lot, it can be worse once you rest and you're still. There's almost an irresistible urge to move the legs. So people often, they'll be sitting there on the sofa and they'll be doing this with their ankles. They'll be moving, and they'll be stretching. I think it's slightly different to the constant jigging of legs you see these kids do with ADHD and stuff. You see people jigging away with their legs. Having said that, I think that my own personal feeling about ADHD, attention deficit hyperactivity disorder, is it may well be a sleep disorder first and foremost. And then because patients are not sleeping well, they're basically taking things in the day like caffeine or Red Bull or Monster or Iron Brew to try and actually perk themselves up a bit. They're all stimulants that worsen restless legs. They then sleep really poorly at night, but they're not aware of it because they're asleep, but their sleep patterns are really poor and they're waking up a lot. They wore a Fitbit, a Garmin or an Apple Watch, they'd see that. They'd probably be waking up 30 or 40 times at night, little lines through their trace. They wouldn't be going into the deep sleep that we need to see. And then in the day, they can't concentrate and focus because they've had absolutely abysmal sleep the night before. So I think ADHD may primarily be a sleep disorder. And then we go and give them amphetamines, which actually worsen your sleep quality. It's just like overdosing on caffeine and Red Bull. It wakes them up in the day so they can focus again, but then it destroys their sleep the next night. So they stay in that condition. So I'm not convinced necessarily that stimulants are a good idea in patients with what looks like ADHD, but when you delve deeper, they have restless legs. Again, I can answer questions on this later if you want. So it's only experienced after rest. It's an irresistible urge to move. It's most severe late evening, and they may complain of a true pain or dull ache. They often wake up feeling stiff or achy, and once they wake up and get up, they're fine. They may also get these sensations of creeping, crawling, itching, burning, searing, tugging. I've mentioned the 4 criteria: an urge to move the legs, it's uncomfortable, unpleasant, sometimes with tingling, the onset or worsening of symptoms at rest. It's not associated with a specific body position. You know, if you get a numb leg when you sat on the toilet, you've just been sitting on your sciatic nerve, that's different. There's rapid relief by movement, such as walking or stretching, and there's this marked diurnal circadian pattern that goes worse towards the night, better in the earlier part of the day. But when they wake in the morning after being still at night, they often have painful or uncomfortable legs. It disappears when they get up and move about. So just before I come on to the secondary causes and associations, it's very commonly associated with periodic limb movements of sleep, which are single, you might see someone who's sitting on the sofa and their leg will suddenly jump, a single little jump. So it's little individual jumps. People may wake up feeling their leg has just jumped. Now, it's not the same as a body startle. I don't know if anyone's ever had the feeling that, they've been just about to go off to sleep and they're fallen off a cliff. And I've always said to people in lectures, it's a crazy place to go to sleep next to a cliff. But obviously they haven't gone to sleep next to a cliff. It's just a feeling you've fallen off a cliff, your whole body jumps. That's a hypnic startle. That's nothing to do with this. But the little individual twitches in the legs. And if you sleep with someone with restless legs, then you'll often see that it keeps happening, and a couple of minutes later it'll happen again. A couple of minutes later it'll happen again. So anything that reduces iron, so iron deficiency, pregnancy, blood donation, renal failure, effective treatments with intravenous iron there, fibromyalgia. So anything losing iron is associated, but it's also associated with fibromyalgia, migraine, depression, rheumatoid arthritis, occasionally with B12 and folate deficiency, and then some movement disorders have it, and as I mentioned before, neuropathy has it, an association with it. When it comes to migraine, I actually recognized this about 10 years or so, 8 to 10 years before the first publication, that restless legs was occurring in about 80% of my patients. And that's when I started getting interested in it. And about 8 years later, someone wrote a paper on it. So it's something I've been very keen on. And if you actually look at restless legs and migraine, there's different associations. It's a bidirectional relationship again. Patients who have, and this is what I talked about, the crystal clear headache-free day. On crystal clear headache-free days, if you're getting no restless legs, we treat the migraine. If you're getting no restless legs, you feel great, you're not fatigued, you wake up fresh, you stay fresh the day, treat the migraine. But if on those days in between the headache where you're crystal clear and headache-free, you're still very tired or you're still getting restless legs, we treat the restless legs, because that may be causing poor sleep quality, which in turn is driving your migraine and keeping it going. So it's a difficult concept, but those people who are fantastic on the crystal clear days, we would not treat the restless legs individually. But those people who still have features of that, whether it's fatigue or the restless leg symptoms, when they're otherwise completely migraine-free, we would think, well, hold on, that needs its own treatment. We look at iron, we look at B12, we look at folate in the blood. And I tend to treat, if ferritin is less than, I put if ferritin is less than 50, but I'm erring towards if it's less than 100 these days. I have a very low threshold for treating with 8 months of iron, not 4 months, but 8 months, if your ferritin is less than 100. If B12 is low and I go for below 300, that's in the lower range and low, I go for a year of intramuscular injections. And then if folate is below 6, I would normally give a 4-month course of a 5 milligram tablet of folic acid daily. A lot of drugs cause this. So pretty much all the antidepressants, with the exception of a couple, make your sleep worse. I don't know if any of you out there have ever been given amitriptyline and had 10 milligrams and couldn't wake up for 2 or 3 days. It's typical for patients with restless legs that drugs like amitriptyline and tricyclic drugs make it worse, but mirtazapine, I was just going to say mirtazapine, I don't know how to go back on this. There we are. SSRIs like citalopram, paroxetine, sertraline, sometimes antihistamines can make it a bit worse. Antipsychotics clearly make it worse. Some anti-sickness tablets make it a bit worse, and lithium can. But caffeine is a huge thing, and I think painkillers are a huge thing, although nicotine and alcohol are also said to influence it. So I've put this up as this is just a graph of what your sleep should look like. We're awake, we go into this is 7 or 8 hours of sleep. We go through 4 or 5 cycles a night, going into deep slow wave sleep, back up to light slow wave sleep, back down, back up, back down, back up, back down, back up. We wake up, we're fine. Now, this is done through polysomnography. You go into a sleep lab, they wire you up with an EEG on the brain, they look at your breathing, they look at your eye movements. These black lines here are rapid eye movement sleep. So you see what happens is you go into the deepest sleep here, stage 4 sleep, and these stages are defined by EEG changes on the trace. Then you go into the lightest level of stage of sleep and you get your REM, or rapid eye movement sleep. Now, the reason it's called rapid eye movement sleep is because you are paralyzed during REM sleep, except with the ability to move your eyes. So if you weren't paralyzed, you'd be moving around. So some people with some neurological disorders, they get something called REM sleep behavior disorder. It sometimes happens with things like Parkinson's or dementia, but it can also happen for its own reason. But what you'll find is they're dreaming about playing football, and instead of actually just being still, they're scoring a goal with trying to kick their wife into the back of the net or their husband into the back of the net. So REM is a protective measure where you're paralyzed. Otherwise, you'd be acting out your dreams, but you can still move your eyes. That's why it's rapid eye movement. So you go back down into deep, back up, and as you go through sleep, you basically you get lighter and lighter. A lot of people who show these graphs will actually go into deep sleep for 3 or 4 cycles. This is just off the internet. This is just a Fitbit or one of those sort of smartwatches. And the only reason I've put this up is that this person is not spending very much time in deep sleep. Now, these are surrogate measures. These aren't actually doing a brainwave test with an EEG. They're wearing a watch that's looking at movement. So it just detects whether it's light or deep sleep, and it does detect REM sleep. And here you're seeing REM sleep is happening. But what you're also seeing is this patient's got waking, every orange line is waking. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19 times that night they've been awake. I suspect, because I've seen a lot of patients with these sort of apps, there's typical patients who comes in with this will say, I'm tired all the time, but I sleep well, I don't wake up. Or I've woken up once. So most people, these very, very brief awakenings, they're not really aware. But once you start fracturing that normal sleep pattern, you see severe problems with fatigue and sleep deprivation, because you need the right duration of sleep. You don't want it broken, and you want to make sure it's having the right sort of pattern of sleep going into deep sleep regularly through the night. So restless legs is primarily a disorder of sleep. And I've already talked about all these things, so I won't go through those again. But if we see it in a headache clinic, and I love this, this is Neil Young album, Rust Never Sleeps. So the relevance of rust is iron and never sleeps. I just thought that was a fun, and I love Neil Young, so there you go. But if we treat people, 60% of patients disappear if we take away their caffeine and painkillers and triptans. And where they revert to episodic migraine, restless leg symptoms often return in the attacks. It's often comorbid with the periodic limb movements. If we treat people with drugs for this, then 60% of people will find that they have drugs for 8 months or so, and then they're fine, they don't need them again. And the other 40% will maybe have them for 8 months of the year, have a break, and then go on them 8 months a year again. I try not to give people with restless legs regular treatment without stopping it. If you do that, all the drugs cause this feature of augmentation, whereby staying on the drug, the brain rebounds, everything comes back, it's worse again. And in fact, you will have seen before that the treatment, things like Parkinson's disease cause this, and dopamine drugs cause it. You may remember in my other lectures, I talked about dopamine in the brain. So dopamine is hugely relevant to the premonitory phase of migraine, where you yawn, you crave food. Those are dopamine-related symptoms. And I asked Professor Peter Goadsby about this. I don't know what's going on there. I asked Professor Peter Goadsby, who's one of the world leaders, if not the world leader in headache. I asked him about, about 15 years ago, is dopamine relevant to headache disorders? Because of, we're seeing the sort of symptoms of dopamine with those things. That sounds very dopaminergic. And then we're also seeing patients getting a need to be on painkillers or need to be on caffeine, because if they don't have it, they're worse. And they think that the painkillers and caffeine are helping them, but actually what's happening is they're not helping, but just when they don't take them, they feel worse. So we're getting this rebound. And it's just the same as addiction mechanisms. So addiction for things like gambling or caffeine or alcohol or cigarettes are all related to dopamine. So I think there's a fantastic story here about dopamine being related to restless legs linking in with migraine. If you take the drugs too long in restless legs, you actually get hooked on them. And when you come off, you'll actually be much worse. But actually, when you stayed on them for too long, you were worse as well. So the whole thing is really, really weird. And quite remarkable. I mentioned already about the B12, the iron, and the folate. This is the thing to give your GP if they want to treat you. So in terms of restless legs in a headache clinic, as I said, we stop all painkillers, caffeine, 60% returns to normal. We give the iron, B12, and folate. But if they're still having, if the 40% haven't gone back to normal, I tend to use low-dose pregabalin just at bedtime for an 8-month course. I give up to 50 milligrams for women, or up to 75 milligrams for men. As I said, 60% will be fine after a course, 40% need another course. I don't give it for more than 8 months without stopping it. Second line, I use something such as Sinemet. Third line, I might use pramipexole, which is a drug also used in Parkinson's disease. But I'm really, really cautious of this drug because this causes impulse control disorder, which is a disorder where people start gambling, becoming hypersexual. I've had a man who bought 17 white vans, even though he wasn't a builder or anything else. I've had someone who used to go to these Victorian rubbish tips to search through old Victorian rubbish dumps, and he'd spend 15 hours there every single day. He wouldn't go on holiday because he had to do this. Yeah, I've had someone who had their house repossessed because they were spending money on online gambling because of this. And even though they've been advised about this, it was a pleasurable thing. So this is what dopamine does. Magnesium spray can also be quite helpful as well, if people just spray their legs with it at night. But pregabalin, low dose for 8 months is ideal. So does restless legs need treatment after detox? Possibly, if you still wake up unrefreshed. Look if it's every day, even on crystal clear headache-free days, or if it's just with migraine, you might not. Okay. Just coming on to low mood or anxiety if restless legs are present. I don't want to use most of the drugs used as antidepressants because they are going to worsen this. So most people for depression, unless they've got hugely horrible, what we call biological features where they've lost their appetite, they've completely lost their libido, nothing makes them smile, they're anhedonic, they wake up at 4 a.m. every morning, everything going through their mind. You know, unless they've got those sort of symptoms, go for the talking therapies, cognitive behavioral therapy. There are a lot of online resources for cognitive behavioral therapy now, but those are by far the best thing to go for first. And consider what the mood's like after stopping all caffeine, because caffeine is a prominent cause of treatment refractory depression. Is their mood normal on crystal clear headache-free days? If so, just treat the migraine because the migraine is going to be driving the low mood. If they've got, as I said, significant biological features, then you might need a drug. And if you're going to use any drugs, the ideal ones are trazodone or bupropion because they don't affect your sleep or cause problems. Okay? Don't rule out or don't miss sleep apnea, which I've already talked about. Migraine and fibromyalgia, just want to talk about very briefly. I've talked in my last lectures about widespread pain. Migraine can cause pain anywhere in the body, and it commonly does. Very, very used to it in the neck and across the shoulders. But you can get it down the back. You can get it into an arm or leg as well. It's not unusual to see fibromyalgia in patients with migraine. And people have often, people are really aware that the same mechanisms occur in fibromyalgia as they do in migraine, where they get what we call thalamic sensitization, these amplification circuits between the brain stem at the base of the brain and the thalamus that amplify things. So not just noise or light, but things like sensations become tingling and then they become pain. And you might even get allodynia where the lightest touch is really, really tender. And these, when we look at them biologically, they're all linked to this thalamic sensitization circuit. The difference with fibromyalgia is, and actually, if you look at the comorbidities, they're the same as those with migraine. If you look at this list, you'll see people with migraine will have most of these so-called things as well. I think the sinus problems and the temporomandibular joint dysfunction are artifactual. I don't think they are true sinus problems. I think they're related to the autonomic disturbance of migraine. POTS is this condition, postural orthostatic tachycardia syndrome, where people stand up and they get a very fast heart rate and they drop their blood pressure. That we do see with fibromyalgia, we see it with migraine, we see it with joint hypermobility syndrome quite commonly as well. So you can imagine how complicated these things are. People with joint hypermobility, they get damage to their joints and then they get widespread pain and they take painkillers. So the whole thing can get really muddled and mixed up here. But be aware of fibromyalgia and migraine. I think the problem with it is that once you've got fibromyalgia, it's almost like your, I don't know if any of you remember the plasma television sets, plasma tellies. You left them on too long and the screen would burn in with the image. And I think the same happens with fibromyalgia. If we leave all these amplification circuits on way too long in certain people who are predisposed, we end up with fibromyalgia and we then can't get rid of it. And if anyone tells you we've got a drug that's going to help you and it's going to turn it off, it's not true. There are no drugs that treat fibromyalgia. And we take people off painkillers in this situation. Sometimes they'll be a bit better, but they'll be no worse. If you keep fueling it with drugs, we make them worse. But there are no painkillers that are going to make fibromyalgia better for the long term. There are no preventative drugs you take regularly, that are going to actually turn this off or make it better. So if we look in the UK, for instance, we have the NICE guidelines. They recommend against the use of painkillers in fibromyalgia. They also recommend against the use of drugs like amitriptyline or drugs like gabapentin in fibromyalgia, because there's no evidence that they work. And actually, drugs like amitriptyline worsen your sleep quality, then you get more fatigue. So there's a lot of reasons why and drugs like gabapentin, you end up on a high dose and you become addicted, and you find that you can't come off them, and then they cause low mood. So we end up causing more problems iatrogenically. In other words, the drugs that we give people make people worse for the future, more than keeping people off the drugs. There are some bits of biology now that are thought to relate to fibromyalgia having a slightly separate mechanism or additional mechanism, and that needs further clarification. So I suspect there are going to be a group of people who develop a certain biology associated with migraine, but they've got a certain way that their brain is made that they're going to actually be very, very vulnerable to this. And it becomes a real difficulty. But just like people with daily migraine, it's no point being on painkillers. We've got really good evidence that regular painkillers for regular pain make people worse in the years to come. And there were big studies, the headhunt studies, over 30,000 people. The biggest risk factor for chronic worsening of pain is the presence of a headache disorder and taking painkillers. And that's beyond doubt. So that's migraine and fibromyalgia. And then that's the study that I was just talking about. It's actually 51,000, not 30,000 patients, the SWAT headhunt study. I'm going to run through those. I mean, there are some interesting sort of associations there, but I'm not going to go through those. I've talked about the pathophysiology, and I've talked about avoiding treatments. And finally, so we're really, really nearly done. How may chronic migraine be misdiagnosed? So you go to a GP and they're going to diagnose you with stress, anxiety, depression, sinusitis, cervical spondylosis, degenerative change in the neck. They're going to do an MRI scan of the neck, which confirms you've got wear and tear in the neck. They don't tell you that if you put 100 people off the street from the age of 30 up or 25 up in a scanner, 100 of those people will have cervical spondylosis, wear and tear, because we're human beings. The ophthalmologist will say it's your glasses, or got a visual problem, or they'll see you because of pain, or pupils are a bit irregular, or you've got a droopy eyelid. The dentist will say you've got atypical facial pain or trigeminal neuralgia, and they make the wrong diagnosis and pull teeth out. The cardiologist and the neurologist will often diagnose you as having blackouts or non-epileptic attack disorder, which is like not epilepsy, it's like the psychological disorder which presents as things that look like seizures. They'll say you've got functional neurological disorder because you've got all these symptoms. And I have a huge problem with that, because it's not this, we're not talking about a psychological disorder here, we're talking about a brain disorder that gives you many symptoms. They'll not look at you when you faint and black out from potential of migraine syncope. Ear, nose, and throat will say you've got vertigo, dizziness, or sinusitis, and they'll drill your ears, they'll drill your nose, they'll do all sorts of things which don't help, but they might help for 2 or 3 months because you had a general anaesthetic, and general anaesthetics can switch off pain for a month or two. Orthopedic surgeons are going to want to operate on these dodgy discs in your neck because you've got neck pain and headache, and sometimes you even get numb arm and tingly arm as part of the headache, and they'll say, oh, it's your disc in your neck. And surprise, surprise, the anaesthetic will make you better for 2 or 3 months, and then it will all come back. So they'll then operate on the next disc. And just don't let them do that unless you've actually got proper neurological signs in a limb with a loss of reflexes or wasting or weakness. Don't let them operate on your neck, especially if it's mainly for pain. The immunologists and endocrinologists, you can spot it in the title there. The people that they were given these patients because they were thought to have post-viral fatigue, after things like glandular fever. So that you end up now under an immunologist or an endocrinologist who treats fatigue, but they have no idea about sleep disorders or neurological disorders. So they don't understand the mechanisms here, and they don't ask the right questions a lot of the time, in my view. And allergy specialist gynecologists will treat you for pelvic pain or premenstrual syndrome. Obstetricians will treat you for excessive vomiting in pregnancy, hyperemesis gravidarum, again, migraine. Psychiatrists will try and treat treatment-resistant depression, anxiety, panic disorder, what we call conversion disorder or functional disorders, psychosis. Gastroenterologists will try and treat your irritable bowel and your abdominal pain. And a lot of the drugs you'll take will make you worse, and you'll end up with alternating diarrhea and constipation because you're taking opiates and other constipating drugs. Pain teams will try and treat all the pain syndromes by giving you drugs and make you worse. And then the pediatricians will say you've got cyclical vomiting syndrome or functional disorder, or you're just a school absentee. And the misdiagnosis then leads to unnecessary suffering, over-investigation, unnecessary operations, antibiotic overuse for sinusitis. 95% of people diagnosed as having rhinosinusitis, when we look at the Mayo Clinic data, 95% of people have migraine, not sinusitis, when they present to one of the most highly specialist clinics in the world. 95% misdiagnosis rates. So if you've got pain above and below the eyes, it's not sinusitis, if it's there at the same time. If it's not green, horrible, gunky discharge and blood and that, and you know, sinusitis is one sinus or the other sinus, or it's this sinus across here. It's one of them, not all of them. And it's green, purulent, horrible discharge and blood. That's sinusitis. Anything other than that, treat the migraine. Stigmatization, really important. People get stigmatized. They get diagnosed as psychological and psychiatric. People get admitted to hospital through casualty. They see doctors. That's the worst thing that can ever happen to a lot of patients. You see doctors and you end up being given drugs. You end up having unnecessary lumbar punctures. You end up having unnecessary scans where we find things that we're never going to cause you any harm, like an arachnoid cyst or a small calcified meningioma. Or someone says you've had a little stroke, but it's just a space around a blood vessel. Or they say you've got white matter changes on your scans, hardening of the arteries. These are things we see in normal people. It doesn't make any difference to your longevity or how long you live with those things. They're not causing you headaches. And patients go around lots of different places to see different people to look at their various different symptoms. But we're all like people with the blind men and the elephant. We're all feeling a trunk or an ear or an eye or whatever. You need someone who actually looks at the whole picture. And you can understand why the GP-patient relationship breaks down and why in England, at least, the NHS is broken. And I think in Ireland, I could possibly say something similar, but obviously, who am I to say? And I love this thought that we've got red flags to suggest you've got chronic migraine as opposed to episodic migraine. And these are the medications that you've taken stop working. You have few crystal clear headache-free days per month, and you go to see your doctor with a list. And I can tell you that your list is only at the top of your list. You have left off the bottom 2/3, 3/4 of your list because you don't like to worry them or make them think you're neurotic. Your list is far longer than actually anyone would ask. And they only want to see your top symptom or your top 3 symptoms. But yet you may not present with headache, and you can have migraine without any headache at all. You might just be tired, pains, insomnia, dizziness, mood, memory, unexplained flushing, swelling, irritable bowel. Chronic migraine is very treatable. 40% respond just to stopping painkillers and caffeine. We treat the sleep disorder if it's still present, things like restless legs. We go for a preventative, which could be a zapping device like Kefali. Oh, that's Wonder Woman, sorry, but it looks a bit like Wonder Woman's headbands, or used to, a little device that goes in the forehead. Gamma Core, we've had a lecture on that before. We can use e-neuro, which isn't really used that much over in the UK. We can use oral drugs, or we can go to Botox. This is the Botox injection sites, or the newer CGRP monoclonal antibodies. And in the booklet we're going to produce, there's going to be a lot on that about CGRP, MABs, Botox, the new drugs, the GPANs, the Ditan drugs. There's lots coming out. And then I'm going to finish on that slide. Okay. And that's some useful information for you. And I'm done. Sorry, I've overrun by quite a long time, but I thought it was probably worth trying to do that properly rather than skimp.